This conference will now be recorded.
Welcome everyone to the TOG session. Today, our TOG is the Acute and Chronic Pancreatitis in Pregnancy, TOG Volume 23, Issue 2. I'm Dr. Amina Firdaus. I'm the co-mentor of MRCOG Health Group. So the title itself is representing a very hard topic, but it's not. I think we will be covering it within 40 minutes. Can you see my screen now? Okay, so let's start with acute pancreatitis. The incidence of acute pancreatitis in pregnancy is rare, and that is around 3 per 10,000 deliveries. The maternal mortality rate from acute pancreatitis in pregnancy is up to 37%, but the overall maternal mortality rate due to pancreatitis is only 3%. The commonest presentation of acute pancreatitis, we all know the sudden onset of upper abdominal pain, most often located in the epigastrium and radiating through to the back, anorexia, nausea, and vomiting as well. So during examination, we may find the epigastric tenderness, reduced bowel sound, fever, and tachycardia. So you have to remember that early low-grade fever is most commonly related to systemic inflammatory response syndrome rather than infection. So what are the differential diagnoses? Hyperemesis gravidarum, preeclampsia, HELLP syndrome, and non-obstetric causes are biliary colic or gastritis. Acute pancreatitis is more common with advancing gestational age and postpartum, which coincides with the increasing frequency of gallstones in pregnancy. So what are the causes of acute pancreatitis in pregnancy? I have marked with blue lines during while I was reading. So it was still there. I have copied the blue box from the talk. So what are the causes of acute pancreatitis in pregnancy? There are a few common causes and there are some rare causes as well. So gallstones, over 65% cases. Alcohol, hypertriglyceridemia, idiopathic. And rare causes are drug-induced thiazide diuretics, hyperemesis gravidarum, acute fatty liver of pregnancy, hyperparathyroidism, gene mutations, and association with severe HELLP syndrome. So, how to diagnose the acute pancreatitis in pregnancy? There are a few diagnostic criteria. Mostly there are 3 criteria, and out of 3, there must be 2 to diagnose the pancreatitis. First one is abdominal pain, typically epigastric, radiating through to the back, serum amylase or lipase more than 3 times the upper limit of normal, and characteristic features of pancreatitis on imaging. So let's see how acute pancreatitis can be divided. Interstitial edematous pancreatitis, which actually resolve in the first week, and there is the necrotizing pancreatitis. The name itself actually represents that it is not a thing that can be resolved in short period. So it occurs in 5 to 10% of patients and happens over a longer period. So there are some scoring system of pancreatitis, like the modified Glasgow scoring scale and also Atlanta criteria for severity of acute pancreatitis. So modified Glasgow scoring scale actually used during in the patient who are not pregnant. But if we want to see the severity of pancreatitis, we may also use it during pregnancy. And score 1 point for each parameter is present. A score of 3 or more puts the patient at risk of severe pancreatitis. So it represents with pancreas, that is P for the partial pressure of oxygen, age for more than 55 years, and neutrophil count where white cell count is more than 15, the calcium level if it is less than 2 millimole per liter. If the urea level is raised, or for raised urea more than 16 millimole per liter, enzymes like lactate dehydrogenase more than 600 units per liter, albumin A for albumin less than 32 gram per liter, and S for sugar, that is sugar glucose more than 10 millimole per liter. So what is the Atlanta criteria for severity of acute pancreatitis? We can divide it into mild, moderately severe, and severe. So in case of mild, there may be no organ failure, no local or systemic complications. In case of moderately severe, there may be transient organ failure less than 48 hours and or local or systemic complication without persistent organ failure. There may be severe, that is, persistent organ failure for more than 48 hours and single or multiple organ failure. So what are the investigations in acute pancreatitis? There are some blood tests, the imaging, and some other tests. What are the blood tests? Arterial blood gas, full blood count, urea and electrolyte, liver function test, and bone profile, lactate dehydrogenase, C-reactive protein, and glucose. So daily blood tests only required if the parameters are abnormal. Otherwise, we have to do it on admission and after 48 hours. Okay. And imaging, what are the imaging we should do? The ultrasound abdomen to look for gallstones at first opportunity after diagnosis. And we have to consider CT, magnetic resonance, MRI after 5 days if concerned about any complication. What are the other tests? The lipid profile if no gallstone is seen. So ultrasound is the first choice for imaging the pancreas and gallbladder during pregnancy, but it is not sensitive enough to detect the bile duct stone in most patients. So further imaging may be required. So MRI with gadolinium contrast is considered safe in pregnancy. Mark that MRI with gadolinium contrast. It may come as an SPA. An abdominal CT scan exposes the fetus to a radiation dose of 1.3 to 35 milligray with levels of less than 50 milligray considered acceptable in pregnancy. So you can see that abdominal CT only give a radiation dose of 1.3 to 35, which is actually safe. So therefore, if CT scan is required in and it is clinically indicated, then pregnancy should not be considered as a contraindication. Now come to the management, how we have to manage acute pancreatitis during pregnancy. The patient must be under the multidisciplinary team. First of all, we have to think about IV fluid to keep up with third space loss to maintain an adequate urine output. Okay, so in early severe acute pancreatitis, fluid requirements of 150 to 300 ml per hour would not be unusual. Input should be titrated to aim for a urine output of 0.5 ml per kg per hour. We should consider about analgesia and also the thromboprophylaxis. And about nutrition, oral intake should be encouraged and supplemented where necessary, favoring the enteral route where possible. If the patient is unable to eat, then passing a nasogastric or nasojejunal tube for feeding is preferable to total parenteral nutrition, though this is occasionally required. So for nutrition, we have to encourage the patient to take orally, and if that supplement also needed, we may advise the patient to take it orally. But if the patient is unable to eat, we may think about the nasogastric or nasojejunal tube. So after that, we have to think about referral to critical care for organ support if it is necessary, and antibiotics should be considered if there is signs of systemic inflammatory response. And imaging for complication, as I already have mentioned, that ultrasound is the best option, but CT scan or MRI should be chosen after 5 days. And then we have to do the treatment of complications. I will discuss later on. The modification of the risk factors to prevent the further episodes as well. So when pancreatitis has been caused by gallstones, current advice is for laparoscopic cholecystectomy to be performed during index admission or within 2 weeks of discharge at 12 to 24 weeks of gestation or after delivery. So there is another TOG. I hope you already have read that TOG, the laparoscopy during pregnancy. So it is advisable to do a laparoscopy during the second trimester. But recently, the American guidelines suggest that it can be safely performed at any gestation. There is increasing evidence that endoscopic retrograde cholangiopancreatography with sphincterotomy and stone retrieval may be used in selected cases during pregnancy with limited fluoroscopy time. At this time, there is no complete guideline for the treatment of biliary pancreatitis in pregnancy, which is one of the reason of the biliary colic is one of the reason for pancreatitis. Triglyceride levels will reduce by a period of meal by mouth or use of a sliding scale. Referral to an endocrinologist is advised. Is that clear up to now?
Yes, ma'am.
Okay. So let's come to the point, the management of complication. So what are the complications of pancreatitis? There are some local complications, some regional complications, some systemic complications as well. So what are the local complications? Acute peripancreatic fluid collection, pancreatic pseudocyst, acute necrotic collection, and walled-off necrosis. Some regional complication, gastric outlet dysfunction, splenic and portal vein thrombosis, and colonic necrosis. And systemic are, as I already said, that the systemic inflammatory response as well as ischemic heart or lung disease can occur. So if complications are present, referral to the local hepatopancreatobiliary or general surgical team is advised, and the patient may require discussion or transfer to the regional tertiary center. So let's see our topic, that is, what is the pregnancy outcome during pancreatitis. Mark that there is increased rate of preterm birth, but they have not mentioned any particular percentage. So delivery is not routinely indicated when pancreatitis occurs. So delivery should be considered if there is clinical deterioration despite 24 to 48 hours of active treatment in moderate, severe, and severe cases. We are not talking about the mild cases. A multidisciplinary approach involving the obstetricians, surgeons, and endocrinologists is desirable. The pancreatitis is not a contraindication to vaginal delivery. Mode of delivery should be based on obstetric factors, based on higher premature delivery rates. The use of steroids for fetal lung maturation should be considered in cases of severe pancreatitis presenting at viable gestation of pregnancy. So we should not forget about the steroid injection if the patient comes in the term, and we can expect that the baby maybe there is a possibility of doing the delivery, so we have to give the steroid for fetal lung maturation. There is also no contraindication to give magnesium sulfate infusion for neuroprotection of the premature infant, and it should be delivered, so that delivery should be required. So that was about acute pancreatitis during pregnancy. Any questions so far from acute pancreatitis? So if a patient came with acute pancreatitis, we have to think about that. First of all, the patient must be under the multidisciplinary team. Then we have to think about IV fluid, whether she can eat orally or not, and we have to be very conscious about maintaining the oral input and also output, that is 0.5 ml per hour, and 0.5 ml per kg per hour. The output must be that level. Then we have to think about analgesia, as the patient will present with severe pain. Then we have to think about the nutrition, and we have to think about the antibiotic as well. And after that, if there is any complication, we have to treat the complication, and also we have to do some investigations to see whether there is any complication or any gallstone specifically. So if the patient does not improve after 24 to 48 hours, we may think about delivery of the patient. And for fetal lung maturation, if the patient is in term, we may go for the steroid injection. And if there is an obvious gallstone, we may go for laparoscopic removal of the cholecystectomy and cholecystectomy at any time period of gestation, as because the severity of the pain and severity of the disease is very important at that time. So this is all about acute pancreatitis. Now come to the chronic pancreatitis in pregnancy. So chronic pancreatitis, it is a progressive inflammation of the pancreas. It causing irreversible damage of the parenchyma that leads to both endocrine and exocrine dysfunction. So the development is multifactorial, but the most common causes are alcohol and recurrent episodes of severe acute pancreatitis. So in case of acute pancreatitis, the most common cause was 65% cases gallbladder stone. But in case of chronic pancreatitis, the most common causes are alcohol and recurrent episodes of severe acute pancreatitis. So what is the exocrine dysfunction? It actually manifests as diarrhea, bloating, cramping with meals, abdominal pain, cysturia, weight loss. Fecal elastase can be used to evaluate pancreatic secretion, but it may not detect mild to moderate insufficiency. Alternatively, a trial of pancreatic enzyme replacement can be used, titrated to clinical symptoms. The dose of pancreatic enzyme replacement may need to be increased in pregnancy. The need for vitamin supplementation must also be considered. Involvement of the nutrition team is a useful adjunct. Often the use of multivitamin will suffice. That is, if a patient comes with chronic pancreatitis with exocrine dysfunction and she's already in pancreatic enzyme replacement, then we have to increase the dose during pregnancy. And also we should consider the vitamin supplementation. What is the endocrine insufficiency in chronic pancreatitis? They said it is complex and it is caused by reduced insulin production, increased insulin resistance, or a combination of two. The pregnant woman with a history of chronic pancreatitis should have an OGTT, should be arranged at booking if she is not previously diagnosed with diabetes. Disease of exocrine pancreas can cause pancreatogenic diabetes mellitus, which we call the type 3C. The combination of malabsorption, poor oral intake, chronic pain, and potential ongoing alcohol use puts these patients at risk of large variations in blood glucose levels and poor nutrition as well. So early involvement of a specialist diabetes team is advised to pay careful attention to the exocrine function of these patients, who are also very likely to require insulin. So the most common symptom of chronic pancreatitis is abdominal pain and often requiring regular opioid analgesia. Eating may exacerbate the pain, resulting in reduced oral intake. So well-managed pain is very important for nutrition, especially in pregnancy, as because the pain increases during eating. That's why patients stop eating and there is nutritional insufficiency. So we have to take care of the pain. So outside of pregnancy, tramadol is the preferred opioid analgesia. It may be appropriate to continue this during pregnancy as well. Pregabalin has been shown to be beneficial outside of pregnancy, but its associated risk of major congenital malformation in the fetus means it should ideally be discontinued in pregnant patient. So if a patient comes with chronic pancreatitis and she is used to take tramadol, we may continue it during pregnancy. But pregabalin, if she's taking, we have to consider that there are some risk of major congenital malformation. That's why we have to discontinue that during pregnancy. And also we have to manage with pregnancy safe analgesia for the patient management of the pain. If the mother has been on regular opioid analgesia, then the neonate will need to be monitored for signs of withdrawal after birth. So this is about chronic pancreatitis, and that's what they have mentioned in Total TOG about acute pancreatitis and chronic pancreatitis. Do you have any question regarding this topic?
Ma'am, what about type 3 diabetes?
Yeah, okay. So yeah, so we have mentioned, we know that there are type 1 and type 2 diabetes mellitus, right? Where there is insulin insufficiency and insulin resistance. But in case of type 3, as we have mentioned, that there are some exocrine pancreatic disease that can cause the pancreatogenic diabetes mellitus, which we have mentioned up, like type 3C. There are type 3A, B as well. So that is another topic actually, and that is a huge topic. If you want to discuss about that, we can arrange another class for that. What do you think? Okay. So, do you have any more questions? Yes, sure.
What is the initial radiological diagnosis of acute pancreatitis?
The radiology, that is ultrasound, may show the gallstone, that is 65% cases.
And when is CT or MRI?
Yes, CT or MRI if after 24 to 48 hours patient is not improving and there is no sufficient evidence of gallstone in the ultrasound scan, then we can go for CT scan and MRI according to the TOG. So we should not go in the first go. We should not go for the CT scan or MRI. The first choice should be ultrasound scan. But if it is not excluding any gallstone and the patient is not also improving, so we have to go for after 5 days. We have to think about CT scan or MRI because there may be a possibility that the gallstone is not visible in the ultrasound scan. Is it clear?
Yes, clear.
Okay, any more questions? Okay, so about I'm not sure who have asked about type 3C diabetes. I will give you a short summary of the type 3 diabetes. Is that okay? In the Telegram group. Okay?
Okay, ma'am.
Okay, I have 2 questions for you. These are the RCOG questions, so related to the pancreatitis in pregnancy. So the first question is, a 38-year-old multiparous woman presents with upper abdominal pain at 33 weeks gestation. She has acute onset of pain radiating through to her back and a history of gallstones and cholecystitis prior to pregnancy. She presents within a couple of hours of onset of pain. Acute pancreatitis is suspected. Her amylase is 4 times the upper limit of normal. What imaging would you recommend to confirm the diagnosis? CT scan of upper abdomen, MRI, MRI imaging with gadolinium contrast, plain abdominal X-ray, ultrasound scan of upper abdomen.
Ultrasound scan.
Ultrasound scan, upper abdomen.
Okay, let's see what they have said. The correct answer is the ultrasound scan of upper abdomen. If diagnostic uncertainty or possible necrosis, MRI without contrast may be used. CT scan is safe, but is second-line investigation after ultrasound if necessary. Okay, and X-ray is not helpful to diagnose the stone. Okay, the next question is, a 35-year-old patient presents with severe abdominal pain at 22 weeks gestation. Serum amylase is raised, consistent with acute pancreatitis. What do you advise with regard to her nutrition? Oral diet and fluids, nasogastric feeding, nasojejunal feeding, meal by mouth and IV fluids, total parenteral nutrition.
Oral diet and fluid.
Nothing by mouth and IV fluid.
Okay, so what we have read in the talk, we have read that when the patient will come, we will encourage her to take food orally if she can. Okay, so let's see what they have answered. oral diet and fluids. If the patient is unable to eat, then we have to try the enteral nutrition before parenteral. Okay. Then we have to think about the nasogastric and nasojejunal. And if at all she cannot, then we have to think about the parenteral nutrition. Is that clear to you?
Yes, ma'am.
Ma'am, if there is pain and serum amylase is increasing, then is it safe to give oral diet to the patient? So,
We will give oral
confusing.
diet to the patient up to when she can tolerate, okay? And most of the time, patient feels that when she eats, the pain will get increased. So we cannot force the patient, but whenever she can able to take orally, we will encourage to take orally. But if we see that she cannot, then we may go through the enteral nutrition. That is a nasogastric feeding or nasojejunal feeding. And if she cannot take that, then we have to go for parenteral feeding. Okay. And also, if the, as you said, the serum amylase is not, it's increasing and not controlled, then we have to think otherwise, right?
Yes.
Okay. Okay. So these are the two questions I have found in the RCOG website, and I want to tell you, all of you, that please check the RCOG website. They frequently gives question about the TOG, and often they give the questions in the exam as well. So you have to be very conscious about these questions, because if you know the answer, there are the clear-cut marks. Okay. So thank you so much everyone for attending the class, and we will meet again soon with the next talk. Any question, anyone?
Thank you,
Okay,
ma'am.
thank you so much. Yeah, thank you.
Thank you, ma'am.